welcome you all to today's session on debunking nutrition myths in cancer care by Dr. Raktim Chattopadhyay, a visionary scientist, entrepreneur, and the founder and CEO of Esperer Onco Nutrition. With a doctorate in cancer biology, multiple global patents, and pioneering research, he has transformed the way nutrition science is applied in oncology. Under his leadership, Esperer has become a global leader in precision oncology nutrition, empowering patients with evidence based, clinically validated solutions that enhance outcomes and survivorship. His groundbreaking contributions were recently recognized at the Asia Excellence Awards 2025, where he was honored as the pioneer in cancer research innovation. Dr. Raktim, we are looking forward to an insightful and engaging session. The screen belongs to you.
Thank you, Dr. Sneha. Thank you very much for Women in Nutraceuticals India chapter, first of all, to invite me to talk on this most favorite subject of mine, that is applications of nutraceuticals in when it comes to the cancer therapy. It's though it's a very vast subject, so I tried to concise it so we can be in the time and we can spend more time on if there is any questions and interactive sessions. So, there are two terms which are very important today to understand. One is when it comes to the nutrition, application of nutrition in the cancer, there are a lot of myths which are available. Because the reason is probably the medical nutrition and nutrition for wellness, these two way different subjects are often mixed. So when we say that well-being or wellness through the nutrition, that means it refers to a healthy human being, and it's more of a preventive way of looking at nutrition. But when it comes to the medical nutrition, it is more often related to the disease, and there the role of nutrition comes as a therapeutic. And this is the most cultivated area today and most controversial as well. First thing is cancer is a multidisciplinary disease. So it's become more complex when you bring nutrition as a science to manage cancer. I always say that cancer nutrition is to be seen always as a complementary therapy. It should not be seen as any kind of miracle therapy, because the main therapy today to manage the cancer is chemotherapy, radiotherapy, surgery, immunotherapy. There are a lot of targeted therapies, hormonal therapies. There are therapies which are established, which helps to cure the cancer, to fight with the cancer. What nutraceutical can do here to complement the main therapy. So these therapies can be complemented by nutraceuticals. So this is the first myth to be debunked. So nutrition alone cannot cure the cancer. So nutrition has to be seen as a complementary role. We'll go more deeper into it while we'll be discussing it. So the two terminologies I was talking about before I start, one is bioavailability and second is biosensitivity of nutrition. Bioavailability is a term which is we often get to hear these terms when it comes to the nutraceutical or drug. So it just how much of nutrient gets into the system, that is we refer generally as a bioavailability. But when we talk about biosensitivity, we generally need less talk in the practice. This is more of a terminology in a research setup. The biosensitivity refers how the tumor host system responds to the therapy, to the nutritions. Okay, so this is something which actually helps to debunk all the myths related to the cancer. So once we understand much deeper the bios availability of applications of nutraceuticals over the bio and the biosensitivity of nutraceuticals, I think the major things gets clear. We will again get into detail as much as possible today. So let me tell you the next slide. Yeah. So this is what we are talking about. We will try to be strict to these topics today. Um, One is precision nutritional approach when it comes to the cancer therapy. We will talk about there are some metabolic myths related to the cancer. We'll also see a little bit of individualized assessment methods. I will not go much deeper into it, but we will say that what is the current trend of assessment of nutritional assessment of cancer patients. And the third, of course, fourth, of course, the cultural content integrations. How do we integrate our cultural content? Because India is a vast country. There are a lot of diversity mm, in the food, culture, everywhere. So how do we integrate those and create a standardized care process when it comes to the nutrition and cancer? Though it is the most difficult part. So now the first thing is once we talk about precision nutrition, you know, this is again a term which we have been using very often, but this is the most difficult terms. Before I get into this, we must talk about I have clearly mentioned here that starvation theory. This is a lot of buzz nowadays on carbohydrate and cancer, carbohydrate intake and cancer. There are two school of thought globally. One school of thought is with coming with a lot of data, a lot of studies, which says that even that ASPEN and ISPEN guidelines clearly indicates that especially in the preconditioning phase before the treatment starts, and even in the during that treatment, how carbohydrate to be restricted. And there are fasting theories. There are a lot of other theories related to the sugar deprivation strategy, which is coming in, and it is being well practiced now, gradually being accepted, and it is being practiced. So fasting has been seen in a very strategic way today when it comes to the managing the nutrition during the cancer treatment. And the second school of thought clearly denies the role of this, and they said that there is no need of carbohydrate restriction as such, and it does not relate to the cancer disease progression. We will not get into the detail, that controversy. Rather, we will talk certain facts of science. Here, what is the fundamental science talks about when it comes to the glucose metabolism in cancer? We must know this before we talk about controversies or anything. Glucose metabolism in cancer cell is indeed very complex. Okay, very complex. If you go to the molecular nutrition, it is very complex. But to make it easy, the fact of science says that glucose metabolism in cancer involves a rapid, inefficient aerobic glycolysis. Please mark my words: rapid, inefficient. Each word has got a sense: rapid, inefficient, and aerobic glycolysis to supply the fast growing cells of the body and to generate the ATPs. Okay. The problem is this process, this fast inefficient aerobic glycolysis in cancer cell, it is driven by oncogenes and tumor suppressor mutations. The problem here, because it is not driven by the normal body metabolism, it is driven by oncogenes. So the control goes to the oncogenes when it comes to the cancer. And because of this, it increases the glucose transporters in the body and the glycolytic enzymes naturally. That the level of glucose transporters go way high when it is driven by oncogenes. And that generates acidic byproducts in the body. And this acidic byproduct creates a survival advantage for cancer cell. Very, very interesting point. So I'm just bringing the facts of science here. How the complex glucose metabolism inside the cancer cell creates a survival advantage for cancer cell itself. So now this is way different from the controversy that we are talking whether sugar to be given or not, carbohydrate to be given or not in the diet. This is we are talking of facts that there are pathways because of these are driven by the oncogenes and suppression mutations driven. So that's what there is a significant amount and hike of glucose transporters and various glycolytic enzymes that creates that entire media acidic. And this acidic media does three things. One, survival advantage. It creates a survival advantage because in acidic medium, the cancer cell can survive better. At the same time, it creates an harsh situation for the normal cell to survive. And this is what creates a big resistance to the therapy or treatment, whether it's a chemotherapy, whether it's a immunotherapy, whether it's a targeted therapy, whether it's a nutrition therapy. All therapies, resistance has been created. So that is the point here. So because of this complexity of the glucose metabolism driven by the oncogenes creates an acidic medium, and that acidic medium is creates a resistance, a barrier to bring the optimal outcome of the main therapy, that is chemotherapy, radiotherapy, or any therapy which is very important for the cancer. So I just wanted to highlight this facts of science here to uh, to 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 address that how the glucose metabolism is complex in the cancer cell other than the normal cells, and it creates a three-way barrier. One, it gives a survival benefit to the cancer cell. It creates an harsh situations for the normal cells, and also it creates a barrier for the therapy that is being used. Okay. Now, if this is something that the science says, then how do you see that carbohydrate into the diet? Okay, let me tell you one thing that once a dietitian prepares a diet, uh, um, I will definitely I have written here that whole food remains still superior than the isolated nutrient or any supplement anything. Supplement cannot be the first choice to manage the inner nutrition care for cancer management. Okay, it is always the whole foods. Okay, so a good dietitian knows the restrictions of giving a or limitations of giving a whole food over the supplementation, and that's how they take a call. But here in this today's topic, since we are talking about precision nutrition, so we are talking about how individual body shows a different sparks, and even the different cancer talks are creates a different situations to accept a generalized strategy for nutritional therapy. And this is very important. I will definitely mention in little deeper into it. I was talking about bioavailability and biosensitivity. So look, in a pharmaceutical, when you look at the pharmaceutical, the pathways are well defined. When a drug goes to the body, how it creates a sensitivity and eliminates or targets the disease, and how the secondary and tertiary metabolites are functioning, everything is well tracked. In nutraceuticals, though it is tracked, but we don't bring into the applications or practice, and that is the problem. So we all, whatever we talk in nutrition, it is at a research setup. In the setup of the practice, when a supplement has been prescribed or a diet has been prepared, the biomarkers are not been greatly considered because of lack of evidences or integrations with our day-to-day practice of cancer care. So this is the gap probably we have to address. And how do you address this? This is not an easy job to address because one is lack of data. Second is lack of instrument to practice it. And that's probably the AI, artificial intelligence comes with some role on this. We will again talk about it a little later. So let me tell you what I am referring here as a biosensitivity. And before that, I will tell you uh, like molecular nutrition in oncology uh, is already evolving from how much gets absorbed to who is likely to respond. I'm making a very conscious statement here. This is a paradigm shift which is happening in the nutritional care process when into the cancer. Let me repeat one. I'm saying that molecular nutrition in oncology is evolving from how much it gets evolved. In the commercial industry, we only talk about how much we are making it available, how efficiently we are making the ingredients available into the system through a term called bioavailability, and we are bringing a lot of technologies, nanotechnologies and other technologies has been used. Fair, good, very important, but it is evolving a little forward. Whatever the ingredient and particle that we are giving, we are able to make it available through the technology into the system. The question is, who is likely to respond to that? And there, the biosensitivity over the bioavailability framework, which actually operationalize the shift by integrating there are traceable biomarkers. I will talk about those biomarkers very briefly here. You know, because if we want to say that, okay, I have proved that this much of ingredient is supposed to be available in the system to give the best results, our journey is not ending here. We have to establish that how this is being carried out to the last mile. Okay, so there are biomarkers. If we can bring those biomarkers through testing, if we can bring it to our daily practice and then decide our dietetic plan, then decide our supplementation, then you look at the drug nutrient interactions and everything. I think we will able to improve the efficacy of nutraceuticals towards the cancer care. Uh, there are pathways, so this is a different subject altogether, but still, since we have working on a concept called like entire globe is working on that gut microbiota has been considered nowadays not even second brain, it is considered as the first brain. So there are a lot of role in the gut microbiota. So we also have done certain work on that personally, and we have seen that the immunomodulation is possible through nutraceutical interventions over the gut microbiota to manage the non-communicable diseases. And we have done some studies on the colorectal cancer as a proof of concept. And we got our global patent published as a DINI access on this particular subject. Okay, you can go to the Google and see it. So here I'm coming back to the subject again. There are certain biomarkers which are becoming very, very critical, like elevated neuronin tryptophan ratios. Okay, the diet, let me make it simplified. The diet which is providing more tryptophan, uh, that will trigger a change in the elevated, neuronin tryptophan ratios, because tryptophan being converted to neuronin through a particular rate limiting enzymes. Okay, so that is being affected, and it has been evident that if this ratio gets changed, that it impacts on the immunotherapy. So whatever the immunotherapy drug has been used, and the patient's host system is this tryptophan neuronin ratios are being distorted, that means more neuronin has been produced. So this particularly affects on the immune system of the body, the way the immunotherapy is supposed to work. Okay, so there are two enzymes involved, IDO and TDO. I'm not getting into that, but this is a simple example where how a diet which is rich in tryptophan, or maybe indirect way it is triggering tryptophan, can distort the ratio of tryptophan neuronin ratio, and hence it can affect the. So there are ways we can estimate the neuronin tryptophan ratios, and in certain cases, especially in the cases where the immunotherapy has been used or prescribed, if we can check this ratio and then we decide that how to. I think probably this is I am referring as a markers to be considered when the diet plan or any supplement plan or nutritional intervention has been given to the patients. The time, I think we are little far, but still, these are the thought process still within the research laboratory. And nowadays, doctors are and the dietitians who are little research inclined, they are considering these facts. Though there are a lot of pros and cons in it, but this is something we must consider. There are many pathways like that, which like arginine, citrulline, urea cycle for the gut barrier integrity. Okay, so this is another one which there is another one like redox control, the ferroptosis nexus, which is to be seen very clearly. So these are like microbiome immune nutrition. I will give you one example, which probably many of you know the Akkermansia is a model where we know that there are strong relations with PD-1 blocker. So the drug which are PD-1 anti-blocker, so there we need to consider it. So that's what, in a clinical case, we see that in a same drug with the same kind of disease, mm, the patients are responding differently. Nowadays, in oncology setup, there are a lot of non-responders being reported, and since cancer has got a combination of drug has been used, and there are regimens which are well defined by global authorities, so physicians has got a lot of options to try one after another. Okay, but in these situations, if we don't consider the gut dysbiosis at a marker level, and we don't consider the gut profiling at a marker level, then probably we'll keep on trying with a newer regimen of drug. Instead of that, if we consider the gut profiling very seriously through the molecular nutrition interventions, probably we can address the many of the non-responding or unexplained areas when it comes to the cancer care. So nutrition cannot be seen just cannot be seen just as a passive or calorie adjunct. The whole point I'm trying to make it here, that nutraceuticals has already been recognized as a molecular co-determinant co-determinant to the cancer therapy, rather than a passive calorie adjunct. And here the role of biosensitivity come, here the role of understanding the I would say that that all the biomarkers comes, and then to relate it with the treatment to be given. So this is, I'm referring as a precision nutrition or nutraceuticals to cancer management. So precisions is not by height, weight, and those things. Precisions also are diet. Precisions also has to come from the certain profile, and which has to come from the gut profile. Now, there are technique available today where, like even we are doing a lot of our patients, we are doing that. From the stool, DNA has been extracted, and entire gut profile has been studied, and from that gut profiling, seeing the sensitivity, we are relating to the final nutritional care to the cancer patients. And this helps to address the optimal outcome of the main therapy. So look, so whole idea of how do we get the optimal outcome of the main therapy, that is chemotherapy, radiotherapy, or immunotherapy, how do we achieve it? So this is only possible through the right nutritional interventions, which has got a power to modulate the immune system of the body along with the drug. So this is the area I wanted to highlight here. Now we will go. So this, I'm not talking much about that. We all know that single diet cure is a bullshit. It is not something that we all understand, that it has to be seen very differently. Fasting protocols we talked about, supplementary nutrition is talked about. Now, see, look, this is a precision's model look like in a practice, okay, where our approach has to be 100% personalized. It cannot be even 99%. When we are picking the biomarkers of the patients, it has to be carefully picked up. If the patient has got a GI cancer, the markers are different for the nutritional care. If it is a head and neck, it is different. If it is a hematological cancer, it is different. It is a breast, it is a different. So the markers are way different for cancer to cancer. It depends completely the site of the cancer. So that's how our precisions of personalization starts from there. So it has to be 100%. It cannot be half-hearted. Then already WHO says, already WHO data has already said that 30% of cancer-related deaths are only because of the malnutrition. So that means the malnutrition has to be tackled, cachexia has to be tackled, muscle wrestling has to be tackled, not only by protein supplementations. I may be looking a little controversial, but protein is a big problem today rather than solutions, if it is not be used when it can carefully when it comes to the cancer. I always say that protein supplementations, protein has vast protein, quality of proteins, and the biology of proteins are way different. So general protein supplementations can sometimes be a long time risk for the patient. Kidneys, even we have seen a lot of patients after 5 years and so they have developed unexplained kidney disease, unexplained liver lesions, and this is maybe coming from there are some link has been made because of the wrong protein mixtures been used. So PDCA score and those things has to be taken care when it comes to the protein. So protein supplementation, I mean, tackling cachexia, tackling muscle wrestling is not about only protein supplementation. There are so many factors has to be taken care. And then there are AI monitoring is another important things which makes the you know which makes the overall cancer therapy, nutritional therapy very, very precise. I'll tell you how. Mm, I mean, we are working on a model where the when the cancer is detected and treatment has not started, we call it a preconditioning phase, nutritional preconditioning phase. In this precondition, see, preconditioning is not a new term for the oncology practice. It has been practiced. Okay, in the drug also there are drugs which are I'll give you one example like pemetrexed. Pemetrexed is antifolate. That's what folic acid is given as a preconditioning 3 days before or 7 days before. So the preconditioning is a very, very well established fact when it comes to the oncology care. Why not for nutrition? The ISPEN guidelines has clearly said that nutritional preconditioning has to be done before the treatment starts. Okay, so we are working in a model where uh, nutritional preconditioning has been done through definitely with SGA and patient guided SGA and all. Apart from that, we have incorporated a AI model in it. Taken the gut profiling of the patients and we are creating an algorithm, and that algorithm can throw a final report. That report can say that how the patient is likely to respond to the regimen of the drug the doctor has decided. Okay. Considering the gut profile, considering the other profile, considering from all the markers and the nutritional status of the body, the response of the drug will be different. Can we give a predictive model on that? We are working in a very primitive phase, but we are working and getting a very interesting results on that particular area. So AI has got a lot of things to do before the treatment starts, especially to identify the response area. Okay, that eventually even goes impacts on the optimal outcome of the chemotherapy or radiotherapy or immunotherapy. So now there are three segments I'm talking about here. One is nutrigenomics integrations, which I was talking about now. Then digital health tools. There are a lot of tools nowadays available, but very few I have seen which is market driven. We have to be market driven here. It cannot be just open ended, and it is not possible, and it has to be standardized as well. And the third is clinical assessment, which I think that in Indian context, it needs improvisation. It needs improvement. Because the current tool which is being used, first of all, the tool is not been rigorously practiced in most of the institute. We have to bring it in the practice and integrate with the main treatment. Bearing some very high level institute in India, I have seen anybody is using very thoroughly, or even if it is being used, it is left as only a dietitian job. So it has to be integrated with the main therapy till the patient lives, even after the treatment. So this is one part. And then also the quality of assessment. I mean, the factors that we considered in the assessment, it is very, very wide and very, very open. So there are ways where we are also working where the assessment has to be seen very carefully. So we get to know. So a physician comes to know when he's starting the treatment, he should know that what is the status of malnutrition status, what is the tolerance level, what kind of grade of side effects may come. So there are a lot of prophylactic uses can be reduced, can be tailored. And during the therapy also, the complication has been managed in a very, very aggressive way, and that gives a long term different effects, especially in the recurrence area or in the post treatment infections profile of the patients are shown differently. So I mean, one is before the treatment starts, how do you see that assessment, and how do you integrate the overall practice? Then during the therapy, how do you manage the drug nutrient interactions and everything to be bring in the current practice, which is not there? And then how do you incorporate a right anti-inflammatory diet to help the treatment? Okay. And then in the third segment, where the treatment is over, patient is cancer free, and that is the time where we see lot of irrelevant infections comes. There are a lot of other complications, comorbid systems conditions comes out. So those things can be well addressed right from the treatment is over till the time patient is there. So I mean that nutrition is not restricted to during the treatment phase. It is from the cancer is detected till the time patient leaves. This is how the nutrition should be seen, and integrated through the various tools and all. It has to be integrated to the practice. So of course we talk about evidences now. We all talk about evidences, and India is nowadays in nutraceutical in India is growing very faster. I mean, it was there, but now evidence focused nutraceuticals is coming up very amazing way. So this is the time probably to standardize those. A clinical trial only cannot standardize a process. Clinical trials may standardize a product or may standardize a particular approach, but overall nutrition care for the cancer patients, if this has to be standardized, I think the multi-level integrations will be required. Doctors, dietitians, government authorities, government institutions, academics, academic institutions, cancer researchers, everybody has to come on a single platform and then to integrate the whole process. It cannot happen. So whatever the evidence today we see, it is mainly either used for the marketing purpose or it is been left out. Even the good studies I have seen is left out and away from the practice. So how to integrate those things into the practice? Like I said, that the whole gamut has to be seen together and then to be incorporated in the policy level to address it. And that I think we have many things to do in this area. So I think I would not go much to it. Here I will stop and I will take 2 more minutes to just to articulate that India's unique dietary habits and economic constraint through locally relevant evidence. So I'll tell you that this is a pharma and nutraceutical. There is a difference. Pharma, if I say that pharma way of thinking, it's always long term. Any pharma company, a good pharma company plans their product pipeline for a long, 10 years, 15 years plan. Whereas the nutraceuticals are extremely good to cope up of addressing the local hubs, which is very important because our gut, our overall genetics builds on the local, what we consume, how do we live and those. So if we create a solution which is not involving the local herbs or local ingredients and things, it may not be successful, unlike pharma. So here the nutraceuticals needs to adapt with a pharma way by thinking, strategizing, and long way of planning of some care product or whatever. At the same time, the pharma needs to take up the quick integrations of the local ingredients, and that's how the pharma and nutrition can go hand to hand to address the cancer as a care. I think this is one of the area where secondly, I was talking about holistic care, which I have already taken that whole phases of the cancer treatment, pre-treatment, during, after, has to be seen as a full system. Then only this holistic approach only can give us a complete solution when it comes to. There is a shortage time, so I kept some time for the discussions if we have any questions. Thank you very much. I can see there is some questions I think has come.
There's a question from
Yeah.
Dr. Jayashree. Where is this acidic medium created in gut or blood?
You mean whether?
Uh, no, Dr. Jayashree, do you want to clarify on this?
Yeah, hi. Hello, Dr. Raktim. This is Jayashree, and I just wanted to know because you said that in the rapid and inefficient aerobic glycolysis that happens due to the oncogenes, the acidic byproducts are created. So I understand that these are the products that are created in the gut and probably, through leaky gut or something like that, gets into the blood. So I really wanted to understand: are we talking about the acid in the gut or in the blood? Because I later in your talk you also mentioned about the microbiome.
Yeah. Yeah, of course. The first place to act is gut. Okay. Uh,
Okay.
that is the concern that we raise because in cancer, the gut because of the dysbiosis, which is a very high, though it it prevents the gut the way it should act. So the entire immune system gets affected when the dysbiosis is at its highest place. So definitely, I was mentioning mainly in the gut, and however, the concept of the molecular nutrition says that uh, the blood is something which also gets affected, and in such situations. So of course, in later part in the serious condition, it's the blood which is also gets acidic.
Okay.
Yeah.
And my actually second question is about this. I understand that we talk a lot about personalized care in many sectors, especially in the cancer care. How do you look at the adaptability and the scalability of these interventions through nutrition?
Uh, yeah, so as I mentioned that I am seeing personally that AI can do a lot in this. Okay, so I'm also personally, we are working on the how AI can do that. So I see that artificial intelligence has got a lot of role, and hence the government is the segment which where we need to see it that how these things can be validated and standardized. Even we are doing the same thing at a government place where we're trying to validate that how this works. So first thing is that there are two things to answer you. One is the holistic approach has to be there. Cancer disease, the day the cancer is detected, biopsy is positive, till the time the patient survives. This is I call it as an entire cycle, and this entire cycle has to be seen in a phase wise. And that is the first thing I would say. And second is different cancer demands a different nutraceutical nutrition interventions. So cancer site specific nutritional approach also has to be brought into the practice. So these are the things, and AI is the right bridge which you can use as a technology to bridge this to address the overall practice.
So, because I understand, I mean, different types of cancers and things. So, have you been able to form at least the dietitians and the clinicians and the oncologists have been able to, define, a cancer specific basal diet. Like, it may be different for others. Like, I think you mentioned something about, what do you
Sugar
say, the
restriction.
anti-inflammatory diet kind of thing, right?
Yeah. Yeah.
So, is some basal kind of thing already in practice?
Yes, yes, it is where we are working, it is already in practice. Yeah. The especially the anti-inflammatory diet and the considering the drug nutrient interactions in the practice, it is already in the buzz. I have seen India, it is there are some oncologists and dietitians. I am working closely with them, and I see that how they are taking it up in their daily to daily practice, and they are keeping a good record of it, which is giving a lot of inspirations. I'm also learning from them. Um, but I have seen in some of the places in UK, especially in the NHS setup, I have seen that they are very, very careful about it. Personally, I was involved in one of the centers where I've seen that how they are taking it very serious. At first place, no patients are allowed doctors to see. Doctor doesn't see without the proper nutritional assessment report. And it has been discussed. The regimen of the drug has been discussed with the dietitians with this context, and then to decide. So this kind of things are taking a lot of buzz nowadays. So I would say long way to go, because when it comes to the India, it's a vast country, and there are a lot of other complications are there, and even the regulations are not as stricter as it is supposed to be. Though nowadays we are talking about recently government says about the medical food has to be seen differently. Okay, the FSMP category has to be seen differently. It has to be reviewed differently. So I think I think it is possible, and we are in the right direction.
Sure. Thank you.
Thank you. Any other question?
Yeah, I think Rajini has posted a question here. Should we recommend antioxidants for cancer patients or not? Is that dose specific or needs to be completely avoided?
Okay, great. So look, the again I will go back to the fact of science. Uh, Cancer chemotherapy, basic chemotherapy drugs, how they work, they generate free radicals, and that free radicals kills the cancer, right? And in these situations, if you give antioxidants, definitely uh, it will it will affect the chemotherapy drugs to act the way. So optimal outcome of the chemotherapy may not come if you give antioxidants during the treatment. Okay, so it is supposed to be avoided. Okay, as per guideline, it is supposed to be completely avoided. I would say antioxidants are contraindicated during the chemotherapy or radiotherapy or during the treatment time. Okay, but after the treatment time, the same antioxidants are very, very important because of the infection profile to improve. There are specific antioxidants which has to be incorporated in the diet or supplementations post when all the cycles of chemotherapies are over. Okay, so that's what I will say. During the chemotherapy or radiotherapy, yes, this is contraindicated, and reason is from the fact of science, I said.
There is one more question from Nikita Desai. Which bioactive food compounds are currently in clinical trials for cancer therapy?
In my based of my knowledge, yes, there are RCT which is available, but still, I don't think that this is something is on priority been taken as of now in India, especially.
Okay, okay. So for antioxidants, as you mentioned that antioxidants should be avoided during the chemotherapy, right?
Absolutely,
So
absolutely.
once the session comes to an end, you basically take antioxidants so that you don't have so cancer is not reinitiated, is it?
Uh, no, that's a very controversial statement. I would not make that. I would say
Okay.
to bring the homeostasis back and to set the right infection profile of the anti-infection profile of the body, this is required. And I'll give you the now from a very basic biology point of view. Most of the cancer drug they pass through urine and kidney, and it leaves some impact on the kidney, right?
Yeah, yeah.
Same with the cardiac muscles. Okay. Same with
Okay.
the cardiac muscles. So how do you bring back? Okay, once the chemotherapy is over, it will be washed out over a time of period. But still, there is always that's what we see. If you see that there is a data which says that post cancer care, the heart rate, heart attacks has been myocardial infections has been increased.
Increased, yeah.
So that is something which tells us that the need of antioxidants after the chemotherapy is over to bring the homeostasis back. So all these vital organs which are somehow affected because of the chemotherapy or radiotherapy or though nowadays there are a lot of targeted therapies have come, even the radiations also there are a lot of targeted approaches has come, but still there are collateral damages. It has to go through the blood. To bring back the homeostasis, yes, post-treatment antioxidants are must, not for recurrence to top because there is no direct connections with the antioxidants and recurrence. Recurrence is a very complex, but
Yeah, yeah.
to bring the homeostasis back, to bring the all the vital organs coming to the normal factor, it's antioxidants is required, especially heart, liver, and kidney.
Okay, okay. But I don't actually remember, but I think a couple of years back I had read about copper being used during chemotherapy. But obviously, we are aware that it is an antioxidant. But I just wanted to understand that when we talk about copper, it has a tendency to act as a pro-oxidant as well, right?
Right, right.
So when we use copper during chemotherapy, we need to ensure that the concentrations are just that it behaves as a pro-oxidant and not as an antioxidant. Is it?
Absolutely,
Okay.
absolutely, absolutely. But still, this has not been standardized.
Okay.
And also, large studies needed to prove that the basic, logic of the science says what you said absolutely right. So
Yeah.
dose titration is one of the way you can avoid those, you know, mm, areas. But still, it has to be standardized with a very large studies, which is not available.
Okay.
Also, do you see the role of, microbiome, like being, refurbished intermittently during, the course of chemotherapy or any other, oncotherapy that goes on, or it should be done at the end of the entire treatment?
No, come on again. I missed your question. Can you just?
No, I'm just trying to say that, so one question was about, like, the antioxidant, and, we do now understand that, antioxidant should only be given at the end of the regimen. But since, the microbiome gets, the gut lining and everything gets disrupted a lot, before and during as well, the cancer treatment. So is there any possibility or any particular, kind of probiotic, or, any therapy has been suggested or used or clinically tried during or after the treatment that is
Yeah, we are doing it. Even we are doing, and that is our area that we are working. So we have segregated the supplementations as a pre, during, and post kind of approach. Okay, where we are focused during the therapy more of anti-inflammatory kind of diet, and the post it is most of intense antioxidant based diet, and the pre is more of a carbohydrate deprivations therapy, like energy has been given from the non-carbohydrate sources like MCT and all. So this kind of strategy is working. We also conducted a good number of trials which is giving a very good results. And even the outside, some of the studies I have seen on this, especially in the nutritional preconditioning area, there are a lot of studies available. So yes, that approach to modulate the gut microbiota, and hence the immune system through the dietary interventions or nutritional interventions, yes, there are a lot of attempt has been made, and most of the attempts has been successful. Uh, I mean, like diet is a major lever on the microbiome that you agree on. But like probiotic monotherapy is very simplistic, which has been used for long term, and But I was talking. That's what I was talking about biosensitivity, which means here that baseline microbial category, that is diversity taxa, and this is the antibiotic exposures, gut barrier status through citrulline. So these are the things has to be taken into the concern. And there are a lot of trial going. So your answer to answer your question, yes, this is the major area today. The whole world is working when it comes to the clinical nutrition and cancer.
all right. Thank you. I actually missed a part of your answer, but that's okay. I mean, I get the crux of it. Thank you.
So I have written my email ID. You can always send me an email. I would love to answer this. No problem.
Sure, 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 sure.
Is there another questions coming in? How would nutrition be adapted for patients with GVDs, particularly involving the GI tract and cancer patients undergo BMT? Is that the question? Hello, Nikita Desai. Hello.
Yes, sir.
Yeah, that's your questions. Okay.
Yeah, yeah.
So what do you do if you don't mind? That's a very interesting question. That's what I'm asking.
Yeah, so I have done my master's in biotechnology and currently I'm working in the field of nutraceuticals.
Okay, okay. So look, GI cancer makes that entire therapy very different. You know that when the tumor is sitting in the GI tract, anywhere in the GI tract, the whole biology works against of everything. Okay, so even the general tactics for nutraceutical intervention fails because it needs a technology to invade. It needs you know absolutely different. And now you are talking about the patients which has gone through BMT. Okay, so there are two things getting affected here in making it very complex. One, the patient who gone for BMT, I mean, you are talking about post BMT situations where iron has got a big role. I mean that you must be aware of the term ferroptosis. Okay, this ferroptosis is one of the marker which works here to be considered here very, and it is evident. The data says that ferroptosis is something which has been, which is to be considered as one of the marker in particular setup that you are talking. Though it is a very complex to answer, but at a prima facie, I would see that the therapist is to be seen it very critically when to manage this kind of situations. I mean, post BMT GI interventions. This is the segment I am referring. I think you are referring the same segment, right?
Yes, sir. Yes, sir. So there are cancers like leukemia, wherein if even after that the treatments of initial chemo or radiations, even after there is relapse. So there are patients who undergo like bone marrow transplant, and the biggest risk during the bone marrow transplant is the GVHD. So during that time, if, whenever your immune system is also low and there is a chances of GVHD, what is the nutritional profile that the person has to basically refer or consider?
See, from the diet, I cannot tell. I'm not a dietitian, but what I can
Yeah,
tell
yeah.
from the nutritional point of view, I can say that in these situations, generally, a very digestive peptides can be a kind of protein applications is something which has been recommended globally. Okay, the protein which has got a very high PDCA score. Okay, so that has been the ion supplementation has to be seen also very critically, and ion supplementation has to be in the there in the body. So these are the two things I can highlight at this juncture. Rest, I think, case to case basis, it will depend.
Okay. Okay.
Hmm.
Thank you.
Welcome.
Do we have any more questions?
Okay, I think questions
Yeah,
are.
all good. Yeah. Yeah.
Thank you. Still, I'll
So,
be available. Questions, yeah.
yeah. Sure, Dr. Raktim. So thank you for such an insightful session. We actually enjoyed the through the session completely, and especially the question answers session. Thank you for taking time out from your busy schedule. I know we have been discussing this for
Yeah.
almost a couple of months
Yeah.
to conduct a session. And secondly, may I also request you if we can also hear from you regarding the market insights as far as India is concerned.
Um, See, clinical nutrition market is, of course, is taking a shape now, getting his own space. But still, cancer nutrition is a very niche area. And
Okay.
as I said that, when you see that market, the protein supplementation takes over. But all the proteins are not supposed to be advised to the cancer patients. That is the major challenge. Second is the antioxidants uses are so rampant. We have seen
Hmm.
in our session also that has to be seen, because these are the factors which are actually, and then not doing the assessment properly. These are the things actually bringing down the segregations of the market. Okay, so it is mixing, creating the volatile situations of the market data once we see. But when you see the practice, yes, uh, practice, the cancer nutrition practice in India, especially, it is, I would say, it is shaping up very well. Most of the hospitals departments which has got a cancer, they are focusing as a separate, they're empowering dietitians, they are focusing cancer nutrition to be seen very differently. There are a lot of trials which has been initiated going on even in the government setup. So I would say that yes, the mm, cancer nutrition as a segment which is coming up well. Only thing is that I think missing link is that it has to be seen from the regulatory point of view. The supplements which is being used for the cancer, which is actually meant for cancer patients. Unless you
Yeah.
control that, the whole purpose will be lost. Which I see
Yeah.
regulated countries in outside, it's very, very strict. Your category of the product are well defined, So there is no
Mhm.
mismatch. There is no mismatch. And then in cancer patients, I personally feel that in cancer patients, every cancer patient should take the supplement, should not take the supplement without the observations of the dietitians or doctors. This is highly recommended, and
Yeah, and what
that is not set in India yet.
Yeah, and what has been observed that the market right now is dominated by protein supplements for cancer patients because we primarily talk about muscle loss.
Yeah, that is
Yeah.
something I was talking. That makes it volatile market. We that only regulator can correct it. That only regulator can correct it because it's very difficult. That is creating the whole system corrupt.
But Dr. Raktim, do you see any primarily any, what do you say, like, the nutritional deficiency, typical nutritional deficiency that you see in cancer patients, basically, like
Uh,
very routinely
yeah.
seen kind
Mhm.
of in all cancer patients?
Yes, yes, of course. To answer this, I will tell you very important things here. There are two categories. One, we fall in a category. The life cancer is a lifestyle disease nowadays. Okay, so we fall in category of calorie sufficient, nutrient deficient category. So this is very interesting to me. When you see the global nutrition report, you see that India is number two or number second in the nutrition malnutrition score. But that means you are saying that we don't have even the we have a huge nutrition deficiency. But when you go to the lifestyle disease segment, you see that there is a calorie sufficiency but nutrient deficiency. Okay. So that
Hmm.
creates a problem. And in cancer patients, 80% of the cancer patients, they are calorie sufficient, nutrient deficiency, irrespective to their economic status. So that
So
means
any particular nutrient is missing, or couple
no,
of nutrients are missing
no, couple of
from
see,
these?
vitamin B and vitamin D and vitamin D is a big problem in India today. Okay.
Yeah.
These are two because these are got a direct role in the immune system as well. So this has been evident that these two vitamins are highly deficient, large scale. But I would say that the deficiencies are not in particular vitamins or minerals. There is an overall chaos because of our food habits, because of the fast foods going high, because of the environmental reasons. So even if we are taking the right or adequate calorie in a day, the proportion of nutrition has not been taken. And secondly, even the proportion of nutrition has been taken, it is not been metabolized right away. So what body needs an active from, they are not getting it. So in a cancer patients, if you
Multifactorial,
yeah.
yeah. Okay.
So calorie sufficient, nutrient deficiency is a problem in a cancer, diabetic and cardiovascular disease segment. The major
Correct.
NCD segment, this is the major area.
True. Thanks so much.
Yeah. Thank you.
Thank you. Thank
Thank you. Thank you, Dr. Raktim. Yeah. Bye.
Thank you so much. It was very insightful.
Thank you.